So I'm going to move in the interest of time to the next case. So 66-year-old male, which now to me is young, had a fall onto the right shoulder. Okay. So here is the x-ray. So we'll start, maybe we'll start on the opposite end with Heinz and have you weigh in on this x-ray. And we're just going to use plain x-rays for this. So for all these cases. So what are your thoughts? How would you evaluate this? And
well, again, no CT, that's what you're saying. So I like to see how all the pieces stack up and what we've got to work with. So I just treated one of these conservatively. It didn't work out too well for that patient. And so I will go in with a plan of possible ORIF, but otherwise probably go to reverse arthroplasty.
anything to add, Joaquin?
I agree that without a CT scan, you can probably not completely understand the personality of this fracture. The grader has a small piece of the head with it, and the head seems to be pretty stable. I think the displacement is excessive for no surgery, so I would recommend surgery, and I would probably try to fix this fracture myself.
So, Mike?
I would say this is an impacted four-part valgus fracture. The GT's blown off the back with a piece of the articular surface probably attached to it, maybe the LT off the front. If you left this alone, it would heal, but the patient would have significant impingement and lack of function. So they would not be as good, I don't think, as the case you showed first time around. So it would be a discussion. And if they were active and they wanted overhead activity, then I think you're obligated to do something here. If you fix it, then you need to elevate that depressed humeral head back up, keeping that medial hinge intact. Very carefully do that. And once the head's back up, you tuck the two Brossies in underneath it, and then you fix it with a plate or whatever your choice of fixation device is. So the technique for doing this is fairly well described, but maintaining that medial hinge is critical when you do it. If you do it and it falls to pieces in your hands during the operation, then I would do a reverse, and that's what the patient would be consented for. But I think probably this is a fixable fracture if they want good function down the road. If they're demented or old or they don't care about going over the head, this will heal. They just have a lot of impingement over its stuff.
George?
I mean, nothing to add. I think Mike did a great job describing this. The only thing I would add is that I'm so used to using CT scans. Me taking this to the operating room and not having a CT scan would be like fixing it without fluoro. So, I mean, I really like to get a CT scan to understand the personality of the fracture.
Gotcha. So, I mean, and I like that. So we got kind of a consensus. This is what our paper was written about before. Consensus on looks like that it's in valgus and you can elevate the head. Agree with Mike. If you elevate that head too robustly or aggressively and it pops off, now you got a real problem. You got a watermelon that's in a pond, you're trying to grab it. And now, when I look at this, I think the CT is a good idea to have this. So, here is the x-ray of this patient, just a little bit different. And so we have kind of gone through this, so I'll jump to what I did. So in this case, I was prepared to do an arthroplasty, but I chose to use structural graft, elevated the head, and try to keep my screws lower in the calcar. I'm willing to take some body blows if anyone has any criticism. Is there any thoughts about what you would have done a little different, or I'm happy to accept any from this panel. But I think all of you guys wanted to fix it. It was kind of consensus on that.
Yeah, I think it looks great. My only, and it probably will heal fine, but on occasion you lose purchase of the head. If you look at the actual head fragment you've got there, you've really got limited purchase of the screws in that head piece, if you can imagine that fracture line. And so sometimes it's a little bit better, I think, to help corral everything in on the sides to help hold the head in place rather than relying just on screw purchase. And there are devices out there that do that.
I think this looks great. I mean, personally, I find that these fractures are the most difficult because there's like bobbing for apples. And that the cuff covers everything. You think it's going to be easy to get a reduction, but they're always challenging. So if I can get a ballpark reduction like this, I think the patient's going to do well. And then you're fighting for screw length. You don't want them too long, so that if the head does clap, they're going to go in the joint. But then you don't want them short, that it's actually going to lose fixation. So you have to find a happy medium.
Fracture surgeons in general tend to be an impatient lot, but if there's ever one time for patients that says Mark described is when you're levering up that head fragment very slowly and very carefully, and take your time, let it breathe a bit more, because if you knock it off, then it's a whole different ballgame.
And I suspect, Mark, that you use a lot of sutures to the rotator cuff as well, right? Because the plate shows you some stability, but I think suture fixation through the cuff is tremendous, and we don't see that on the x-ray, right?
Yeah, no, so my theory is like kiteboarding. I got cargo netting that's holding everything down, so you don't really see that, but they are very powerful. I tend to use tape, so I like the tapes, and I don't think they break as easily through the plate. Because any suture you put through a plate eyelet can break. Sometimes I'll tie the sutures to the plate first and then tie into the cuff and tie over the top. So I think it's a soft tissue operation with a bony component. And the most important thing though in this is that I've been there when I've knocked the head off, and it's not fun once that happens. So, take it slow is what I'd say here.
Mark, if you did knock the head off, what would you do?
I'm sorry?
If you didn't knock the head off completely and it was completely free in your hand, what would you do?
Then the age does play a part. I mean, if the guy's like a physiologically older, 66, I'm probably going to do an arthroplasty, because once you get, it's like you're a hockey guy, right? It's like a hockey puck. That thing's on the ice and it's moving. So it's hard to get. So I don't want to spend all day and have an infection. So I'd probably move on. But I think that if you're very conscientious and elevate it and are kind of slowly levering it up, and as you do that, everything falls behind it. So the tuberosities come back around.
Christian Gerber has described using a lamina spreader. Have you guys ever, I've never used that. Have you guys used that to elevate the head, a lamina spreader? Or do you use an elevator? I use an elevator myself.
I like the Bogan elevator, the bent wood handle elevator. It's like one of my favorite tools. It's something I really enjoy using. I think it's very helpful because I don't like something that's too small and sharp, because I think I can penetrate through things. So a medium face or a Bogan.
Hey, Mark, can I ask you a question? Just a quick one. Mark?
I'm sorry.
Can I just ask you a quick question?
Oh, sure.
Yeah, if you go back, you said that you like to place most of the screws in the, did you misinterpret? I thought you said you like to place most of the screws in the inferior portion of the head.
I didn't quite get what you said. I'm sorry, George. Did you?
I thought you said that you like to place the screws into the more inferior portion of the head when you're fixing these.
Yeah, no, I mean, I think I'm still a Mike Gardner disciple in the Calcar or kickstand screws. I think having, Calcar screws is very, very important. And I like to run those long and low. I think that helps. So when I'm doing this, I think, I always use the analogy of hanging a tomato from a rake. I mean, I'd rather put the tomato on top of the rake. So keep them